externa. Sometimes I see this given because it'll dry out the middle ear. Well, maybe if the kid has allergies and it decreases swelling in their nose and their ears can drain, but in general, it's not going to clear the middle ear space, and don't use it for sinusitis. No clinical indications in these circumstances. All right, first generation histamines. Let's get to it. Benadryl, does it have any role? The reason's not to. It's poorly selective, right, on H1 receptor action. It also has serotonergic, it has alpha-adrenergic, so it has neurologic effects. It causes sedation and cognitive impairment, especially Benadryl and hydroxyzine. You're at risk for overdose and you're concerned for neurologic and cardiac side effects. So neuro side effects, CNS depression, seizures, and coma. It can cause arrhythmia and especially prolonged QT. Hydroxyzine in kids under age 2 is especially dangerous. Possible but not preferred clinical uses for H1. Definitely don't use it for allergic rhinitis or urticaria. Maybe for insomnia, but actually melatonin is preferred. And remember that H1 blockers, first generation, they actually distort sleep architecture. So the kid might fall asleep, but they're not necessarily getting good sleep. In terms of motion sickness, I see it used a lot. Behavioral intervention is actually the first line treatment or management for motion sickness. A backup would be Dramamine and Benadryl, but you go to your behavioral stuff first. Make sure they're seated in the proper position, no meals beforehand, stuff like that. In terms of appetite, I do see cyproheptadine used in kids greater than the age of 2. That might be the one circumstance where I see legitimately a first-generation antihistamine used. Okay,